Welcome to The Explainer. Today, we're diving into a really interesting new Phase 3 trial from the Lancet Respiratory Medicine. It's taking a hard look at a new third-generation EGFR inhibitor, Limertinib, for non-small cell lung cancer. Okay, let's get right to it. The big question here, the one we ask every single time a new oncology drug comes out is, so what? Does this actually change how we treat our patients? Is Limertinib a real contender as a new first-line option? So here's how we'll break it down. We'll walk through the trial design, then hit the top-line results, dig into the subgroups and safety, and then try to figure out what it all means for our practice. So what exactly are we looking at here? The goal of this study was pretty straightforward. The researchers wanted to see if Limertinib, a new third-gen EGFR TKI, could outperform a first-generation standard, in this case, gefitinib, in patients who haven't had any prior treatment. You know, the investigators put together a really solid study here. We're talking a multi-center, randomized, double-blind, Phase 3 trial. It's exactly the kind of rigorous design you want to see to get a clean, clear answer. Let's look at how they structured it. All right, so who was in this trial? They enrolled 337 patients, all with those classic sensitizing EGFR mutations, exon 19 deletion or L858R. And crucially, these were all treatment-naive patients. They were split 1-to-1, with one arm getting Limertinib and the other getting gefitinib. The main thing they were looking for? Progression-free survival. That was the primary endpoint. And that brings us to the results, which really is the punchline. This is what everyone wants to know. How did Limertinib actually perform on that primary endpoint? The median progression-free survival for patients in the Limertinib group was 20.7 months. I mean, just let that number sink in for a second. 20.7 months. And this is where it gets really dramatic. You've got 20.7 months for Limertinib versus just 9.7 months for gefitinib. That's more than double. We're talking an 11-month difference in median PFS. That is a huge leap forward compared to the older drug. Now, let's look at the stats here because they really back this up. That hazard ratio, it's 0.44. So what does that mean in plain English? It means a 56% reduction in the risk of the disease progressing or death for patients taking Limertinib. And with a p-value that's off the charts, there's absolutely no question this is statistically significant. Okay, the headline number is impressive, for sure. But as we all know, that's only part of the story, right? For these third-gen TKIs, we have to look deeper. We need to know about CNS activity and the side effect profile. That's what really helps us make decisions in the clinic. And here's a huge one. CNS metastases. This is a critical hurdle for any new TKI. Can it get into the brain and do its job? Well, it looks like Limertinib really flexed its muscle here. And the data for patients with brain mets is, wow, it's maybe even more impressive. Look at this. Median PFS was 15.2 months on Limertinib, compared to just 8.3 months on gefitinib. And that hazard ratio? 0.35. That's a 65% reduction in the risk of progression or death. For these high-risk patients, that is a really, really big deal. Okay, but what about safety? You know, the side effects. Interestingly, the rate of serious adverse events, grade 3 or worse, was basically the same in both groups. But the type of side effects was totally different. With Limertinib, you're looking at more diarrhea, more GI stuff. With gefitinib, it's more about elevated liver enzymes and rash. So it's not that one is safer, they just have different profiles we need to anticipate and manage. So this all brings us to the big question, doesn't it? We have these really compelling results, but how do we fit Limertinib into practice? Where does it stand in a world where, for many of us, another third-gen inhibitor is already the established standard of care? Well, the authors themselves are pretty direct. They say, look, Limertinib showed superior efficacy, the safety is manageable, so it should be considered another first-line treatment option. And, you know, that's fair. But we've got to put our clinician hats on and really look at the context here, and especially the limitations. There are a few really important things to keep in mind. First, the big one. The comparator was gefitinib, a first-gen TKI. It wasn't compared to a third-gen drug like osimertinib, which is the standard of care in a lot of places. So we don't know how it stacks up head-to-head. Second, this was an all-Chinese patient population, so we need to be careful about generalizing to everyone. And finally, we don't have the overall survival data yet. And while this PFS benefit is fantastic, OS is still the ultimate goal. So let's distill all of this down. What's the clinical bottom line? What are the things you can actually take away and think about for your practice tomorrow? It really comes down to three things. First, it's clearly superior to the older standard. Limertinib absolutely blew Gefitinib out of the water on PFS. Second, you're dealing with a different but manageable safety profile. Think more GI toxicity, less liver toxicity. And third, this means it's a new first-line option. It's another powerful tool in our toolbox. And that leaves us with the ultimate question for you to consider. Is this practice changing? Or is it another really strong option in what's becoming a pretty crowded field? With its impressive PFS, especially in the CNS, but that distinct safety profile, where does it fit for you? That's the discussion worth having.